The question of diagnosis in psychiatry is a bit of a loaded gun because there is what we call a very poor interval reliability in psychiatry, meaning that you can have one patient with the same symptoms going to see two different psychiatrists and come in with two different diagnoses. At the same time, you may also have 100 patients with exactly the same symptoms being given 100 different diagnoses. So when we look at the diagnostic criteria for a disorder such as depression, we see that a person needs to fulfill 5 out of those 9 criteria. If you actually look at it mathematically, there are tens upon thousands upon hundreds of thousands of different combinations of symptoms that may lead to a person feeling depressed. So for that reason, we've identified what we call core symptoms of certain psychiatric conditions that people need to have in order for them to fulfill a diagnosis, for example, of depression. Now, in depression, the two main core symptoms are a lack of ability to feel pleasure and joy in things, which is something that we refer to as anhedonia. And the second core criteria is a lowering of mood, more days than not, for the better part of the day, for a minimum period of 2 weeks. When a person has those symptoms, there are very often other associated symptoms of depression. And this can include changes in appetite, sleep, energy levels, as well as ability to concentrate and focus on tasks. And when people become very, very depressed, they may experience suicidal thoughts, suicidal behaviors, and in some instances may even become psychotic. And by psychotic, I mean that they experience things in their reality that are not real. So hearing voices, a voice telling you that you are worthless or nothing or should kill yourself, is generally a very, very serious sign of depression. Now obviously when the condition is the most severe, it is the most obvious, and would therefore people would be most likely to take their relative for help when the condition is so serious. But it's when the symptoms are very subtle and may not necessarily reflect a significant change in that person, but still might be cause for concern. And this could be something as subtle as withdrawing from friends and families, finding a lack of pleasure or enjoyment in work or in social relationships. And at other times, feeling angry and irritable and sometimes anxious. There's certainly differences between men and women in terms of how men and women present with depression. And certainly in my experience, men tend to present more often with irritability, short-temperedness, poor frustration tolerance, domestic problems, as opposed to women who may present more typically with a low mood, tearfulness, sleep disturbances. Although nothing in psychiatry is absolute, but it sometimes gives an indication or helps to show the differences in gender in terms of how patients may present with these conditions. The most dangerous form of depression is an untreated depression. Whether the person is receiving medication or psychotherapy or social workers intervention, it doesn't matter. The most dangerous depression is an untreated depression. Therefore, it may be overcalling it, and it might mean that too many people are going to see the doctor because they're worried about being depression. But in my opinion, you can't overcall it enough. And if there is even the slightest hint or suspicion that this person may be depressed, it would be good to seek medical advice and medical assessment. It doesn't necessarily need to be with a psychiatrist or with a specialist. Any medical doctor is trained in mental health conditions and would be able to diagnose and treat depression. If those initial treatments are unsuccessful, that's generally a very good indication to refer to a psychiatrist. So what I would say to people that are watching is if you are even in the slightest bit concerned that your relative might be depressed, take them to go and see someone. There's a tendency for people to think that when they go and see a psychiatrist that it means that they're going to get admitted into a hospital or locked up or never be released or be subjected to electroconvulsive therapy without their consent. And these are all Hollywood myths and Hollywood lies. And the treatment landscape has changed significantly over the last 20 years in mental health to shift more towards advocacy for patients. And we are not in the habit of taking patients' rights away from them. We want to help patients and we want to empower them with the correct treatments. Very often we will also hear relatives saying things like, he must just put on his big boy pants. He must just put on a stiff upper lip. Don't let these things get to you. Just be strong and push through. And if it were that easy, I would be out of a job. Because the vast majority of patients know that. It's intuitive to think, I'm feeling down, I must make myself feel better. But for some people, they are just not able to do so, and in fact need additional support, help, and advice from professional people. The difference between mental health conditions and physical health conditions is that you can see a physical condition. With a mental health condition, it is sometimes very difficult to visualize it, but can at the same time be as disabling and debilitating as any other physical condition that patients may be diagnosed with. When we think about depression and the outcomes of depression treatment, there's a lot of debate and contention amongst professionals in terms of how well do medications work, how well does psychotherapy work, and does medication or psychotherapy work better than one another, or is sometimes waiting and letting things evolve by themselves might also be a treatment approach. When we look at success rates, the results for antidepressant treatment are, in my opinion, quite disappointing, in that about 50 to 60% of patients will respond to a treatment and that they will have a resolution and relief of their symptoms. However, that also means that 40% of patients may not have a successful resolution of their symptoms. It doesn't mean that the treatment has failed, or that the patient has done anything wrong, or that the patient will not be better. It sometimes means that we need to think a little bit more in terms of the diagnosis, the choices of medications that we choose to use, and the best way to actually treat that patient. And the ultimate end goal for any patient with a mental health condition is complete and absolute remission of symptoms. And by remission we mean either almost none or totally no symptoms. And for people to achieve complete functional recovery and sustained remission in psychiatry, and I'm not only speaking about depression but other mental health conditions as well, is disappointing. We are sometimes not able to completely eliminate symptoms, but are very often able to reduce symptoms to the point where the person feels functional and is able to live a full, happy, joyous life with their friends and with their family. But to normalize that, when we look at other areas of medicine, in terms of how well do medications or treatments work in general, some people may disagree with me with this, but the outcomes for many medical treatments, for even physical conditions, is disappointing at best. There are very, very few conditions in medicine that we can cure. In fact, it's mostly the physicians who are able to cure things with antibiotics. But in psychiatry, there are very few cures. And we must be very careful about selling our treatments to patients as a cure. When we think about depression, it is a relapsing and remitting condition that goes through periods of turbulence and difficulty, and that is also balanced out with periods of stability and happiness. And to have a more sort of realistic long-term approach towards depression and giving patients that information can also help them create a sort of more realistic expectation of what is to come from their treatments.